Hello everyone. So today we are going to do the voiceover on this lecture. These PowerPoints are available on the website uh, www.neomanzar.com. So let's start the presentation and see if we all can learn together. So of course, as the first slide, this is the introduction slide, and it's very evident here, as you guys can see, that there are different ventilator you can use, so depending upon your hospital policy, but basically the principle honestly remains the same, especially when we are talking about conventional ventilator. So there are different types of ventilator, as you guys know, that there's conventional ventilation in neonates and there is high frequency ventilation, and there are two types of high frequency ventilation. One is jet and the other one is oscillator, and that is the another talk. We're not going to cover the jet ventilator here. So let's proceed and see where we are. So basically, the title said, that neonatal ventilation is an art and a science. So the scientific part is knowing the physiology of ventilation, while the art part is that really you have to tailor it according to the need of the baby's lung, and the compliance, the physiology of the lung, it keeps on changing honestly minute to minute. And actually we did a study where we look at minute to minute when variation in tidal volume, and it was really interesting, and you guys can google that article. The title is minute to minute tidal volume ventilation difference. So anyway, so let's just stick to this talk. So who should be supported, when support should be considered, and how should the support be provided. So who should be supported? Of course, anybody who is going to have respiratory failure. So neonatal ventilation is not needed for, let's say, transient tachypnea of newborn, or newborn with slight moderate distress. It has to be the respiratory failure. Of course, respiratory failure is described as clinically where the neonate has reached a point where you cannot ventilate by just by observation. So this is who. When it should be supported, when your all things are maxed out, which means you're observing your gas is suddenly deteriorating, the pH is falling down, the PCO2 is going up, the oxygenation is not right. So that means that you're maxing out on the physiological processes. So now you have to ventilate this baby. So how should the support be provided? And this is the meat of the talk today. So basically it could be invasive or non-invasive. Invasive of course means that you have to have the endotracheal tube, and non-invasive means you can do it through the nasal prongs, and different types, and there are different modes. It get confusing, but honestly if you just remember the concept, this type and mode is not really difficult to understand. So what is the diagnosis of respiratory failure is based on? So of course your clinical examination, signs and symptoms, tachypnea, respiratory stress, then desaturation, then blood gas like we talked about, pH, PCO2 and PaO2, and you all know that pH is going down, PCO2 is going up, and O2 is going down, which is PaO2. And X-ray findings, lung fields, how is the pleural space. For example, a baby who has sudden development of pneumothorax will go into respiratory failure. The management is entirely different as compared to a baby with slight fluid in the lungs. So what is respiratory support? Of course, you start with first is oxygenation. You have to do nasal cannula head box. Then we talked about non-invasive ventilation. We are going to touch about the invasive ventilation, and then we'll just touch base a little bit about the ET tube or endotracheal tube and CPAP. And you guys all know that how insure, which is intubation, surfactant, and extubation, and then putting on CPAP. So these are certain studies which have done to show that non-invasive ventilation is as good as invasive ventilation. Earlier, like 30-40 years back, there was a time when the tube was left in situ for a prolonged time, and people have noticed a lot of complications, especially subglottic stenosis. And then since the advent of this concept of intubating and providing surfactant and extubating, the outcome has really changed. And of course, the ventilation strategies. So like I said earlier in the intro, that is conventional or high frequency. So let's talk about conventional ventilation. So conventional ventilation is pressure or volume control. So again, remember the word control. If you are controlling, or the provider is controlling the pressure or providing the pressure parametrics, that is, or parameters, that is the pressure ventilation. If the provider is providing the volume as in the ventilator, and the pressure and all that is calculated, that is volume. So again, in summary, if somebody say patient is on pressure control ventilation, which means the pressure parameters are provided. If somebody is saying that patient is on volume ventilator, it means that the volume parameters are provided. And of course, depending upon the cycle, is it flow cycle or time cycle? So again, as the words say, once a certain amount of flow is reached, the inspiration is halted and then the expiration starts. Same thing with the time. You can do a time cycle like 0.3 is the I time. So after 0.3, the inspiration stops and then the expiration starts. Patient triggered, what you can do that instead of you taking the control, and this is the really strategy we are using for a long time now, but like I said, 40 years back, people were paralyzing neonates to ventilate, but now gradually we realize the ventilation when the patient is awake is much better, and when the patient is awake, it's better to have a patient trigger ventilation. So basically it's just like the analogy that you have the side wheels on the bike and gradually you take out that and let the patient do the thing rather than you do, or the ventilator do everything for the patient or the infant in our case. So synchronized intermittent ventilation is one, assist control and pressure support. The concept is the same. Basically, you are supporting, just remember the analogy of side wheels on the bike, that basically you're just supporting, and at the time come when patient is doing everything good, you just take out that support and let the patient extubate. So again, these are some graphics. Like I said, these are old graphics. They're nice presentations on these graphics these days, but the whole idea, like I said, I'm just doing a voiceover on this old presentation as some of you requested. So basically IMV, as you see, intermittent mechanical ventilation. So the ventilation is happening as you see here, and this is infant breath. The problem is ventilation is putting their own breath and infant is producing their own breath, so there is asynchrony. So you don't want that. You want really a see here is everything synchronized. Like when the patient started to take a breath, the ventilator gives a breath to basically support that, or what you call assist that. That's what assist control. And then you have the same example. So basic idea is the difference between IMV and SIMV. So you want the ventilation to happen in synchrony. That way the mechanical breath and infant breaths are synchronized. And this is another example. Like I said, in assist control, these are the waveforms: pressure, flow, and volume. And you see how infant's breath are here, and this is in pressure support. In assist control, both are working in asynchrony. This is another very important graph to remember, and especially those who are going to take the board exams. This is the thing you have to understand. So basically you can start with one thing, which is PIP. So PIP is basically the peak inspiratory pressure. This goes this way, then this is the PEEP which remains here, this is the rate, and then this is the flow. So again, the graph explains it's all very well. And these are the volume curve, and you see how in IMV and how in SIMV and how it assists control. That again, the whole idea is to reiterate on the same point that synchronizing the breath cycles is very important for better ventilation. Now let's do some cases. So case one, here we have a premature female infant. The birth weight was 690 gram, born at 25 weeks of gestation. So she was noted to have tachypnea, grunting, nasal flaring, and subcostal and intercostal retraction. Of course, based on these clinical findings, we all know that this patient is in respiratory distress. So something has to be done. So examination showed poor air entry. Then X-ray showed hazy lung field. And then the gas was 7.2 pH, PCO2 of 64, PO2 47, and this is base deficit and bicarb. So intervention, we all agree that now we have to support. So what do you want to do? You want to start nasal cannula? You want to do CPAP? What do you guys think? Think about it. Yes or no? Okay, so the options are, you can try the CPAP based on the Quine study. You can do that if you want to. You can intubate, especially with this baby who is already premature. And at this point, I want to tell you something, the difference between a rescue surfactant and prophylactic surfactant. Many centers, if the baby is very premature, let's see 25, 24 weeker, they intubate in the delivery room. So that way, is called a prophylaxis. You don't wait for these respiratory failure to occur and then do the rescue surfactant. So, but again, it's practice dependent. There are many studies comparing and the trial. So whatever your practice is, just follow that. There's nothing like a better or a worst option in terms of prophylactic or rescue surfactant therapy. So like in this case, you can either start with CPAP or you can do the insure, intubate the baby, give surfactant, extubate, and at this point you can decide to either put the baby on CPAP back or you can put the baby on non-invasive ventilation. And again, you can put non-invasive conventional or you can put non-invasive high frequency. And like I said, the science is changing, so we have to adopt to that. Or the other option is just leave the tube in, don't extubate and do the conventional ventilation, or leave the tube in and do the high frequency ventilation. So see how this case is progressing. And in reality, really honestly, it depends upon the unit practice. Like for example, certain units, what they do for smaller babies like 25 weeker, they intubate and put the baby on high frequency ventilation right away. Some people believe that there's no need to go on high frequency, they do the CMV. In CMV, some people do the pressure ventilation, some people do the volume ventilation. So there is a lot of controversies in ventilation. But again, just follow one of the trend. Basically, you have to know the pathophysiology of ventilation. That's more important. So let's see, after intubation and ventilation for 30 minutes, this is the X-ray, and the arrow points out that you still see, some haziness there. Tube looks it's slightly deep here. You guys can comment on that. So now after 2 hours, and you see that now we see some, the tube is slightly high now. It still looks a little hazy. And so let's see. So this is now case 2. So in case 2, it's a 6-day-old premature infant. The current weight now is 670. The birth weight is 720, so almost lost 50 grams. And this patient is ventilated on PRVC. See, again, when you have VC, volume control, so basically you are controlling the volume. So this baby is on volume ventilation. And now with the support of intermittent ventilation with pressure support. So now what is happening? This is the tidal volume. VT is the tidal volume, and tidal volume is usually 5 per kilo. The rate is 40 to 60. You can start pressure support here. They decided to go 7 above PEEP. So basically 7, 5 plus 7 is 12. So 12 is your pressure support if you add PEEP to it. So these are the settings. The blood gas is pH is 7.2, PCO2 is 69, O2 is 34, and these are the base deficit and bicarb. And this is the CBG. So basically what they are saying, you cannot rely much on the PaO2 because this is the capillary gas. So now let's see what happens. So chest x-ray was performed, and this is the chest x-ray. So you see like really there's like a little bit of loculated air. This is again like a certain PIE, the baby's intubated, the tube is here. So it doesn't look like a pneumothorax. It could be like emphysema, what we call interstitial emphysema. So anyway, the case continued. So the option here, do you want to change from CMV to some other ventilation? What do you guys think? Change to oscillator. That's what people do, or especially with PIA, you can change to high frequency jet ventilator, because jet ventilator you have a better way of ventilation, and especially if this PIE, you can control with the jet and give more expiratory time. Because if you remember, in jet ventilator the expiration is basically passive as compared to oscillator ventilation. And again, I said this is not the talk about the high frequency ventilator. There are many presentations on YouTube you guys can watch, but just to give you a concept clinically, like how the case progresses, and you have to go from science to art in neonatal ventilation. So like so far we talked about conventional and high frequency, intermittent and synchronized. We said assist, pressure control. We said what is PRBC. So basically these are confusing words, but as long as you understand what they're talking about, it's just the art of how you ventilate the neonates. So again, like we said, we talked about these differences. Again, I'm showing the slide back to you just to revise it. Now back to the case, 2-hour-old premature with RDS. So the blood gas now, we already talked about, shows respiratory acidosis, and then decision was made, to change from CMV, and then volume control. The patient was on volume control. We said we'll do assist control, and then the follow-up gas was this. So PCO2 has come down, the pH has improved. So what do you guys want to see? Wean something or leave everything the same? What do you guys want to do? Okay, so remember this, recall that which one is, so this was your PEEP, this was your rate, this was your flow, this was your PIP. So you guys, and this is your inspiratory time. So, honestly, it's very easy to remember. See, like I said, and they just mentioned it to you again. So now what are the default setting in a premature baby with moderate RDS? So like I said, in volume, if you are doing a volume controlled, pressure regulated, assist control, you can start somewhere here. If you are doing the SIMV with pressure support, you can do this. Again, remember, these all assist control and SIMV pressure support are the patient trigger ventilation. You are helping the patient. It's a weaning mood. You are not really taking, ventilator is not doing everything for the baby. Ventilator is just assisting the baby to breathe well. So if you remember that concept. And for high frequency ventilation, the settings are different, and this is not the talk about that. And for the jet, again, we have some YouTube video on jet. If you can Google our Neonatal and ICU, you will find 5 or 6 presentation already on high frequency jet ventilator. Now case 2. So this is the follow-up gas, 7.18. PCO2 has gone up, and O2 is down. Oops, something must have went wrong. So remember, dope, displacement of the ET tube, obstruction, pneumothorax, or extubation. So this is the mnemonic, if you want to remember like that. So chest X-ray was done, and let's see. And then the chest X was taken. As you guys can see now, this is really hyperventilated lung here. And so what is going on here in 3A? And in 3B, you see like there's still some air pocket here. So what's going on? Now at 4 a.m., now you see this is pneumothorax, and this is very classic. See how the air is trapped here and the lung is pushed. So this arrow showed how the lung is pushed, and then this is the pneumothorax. So now figure 4B is showing they have inserted or evacuated that by the inserting the tube, and look at the gas on the same baby. They said is improved now. So at this point, again, the question is, should we go back to conventional? Should we continue in high frequency? Again, with the air leak, it's a better idea to try the baby on high frequency ventilation, and especially jet ventilator. And again, it's a preference, honestly. Like I said, the people can debate. But anyway, the gas is further improving here. Actually, now it's more on the alkalotic side. So now they repeated the X-ray, the right looks okay, and now the patient has what we talked about earlier, PIE is pulmonary interstitial emphysema. So now what is PIE? It's because of, again, the question is when people debate about pressure ventilation versus volume ventilation. So remember, both can cause trauma. One is barotrauma and one is volutrauma. So if you give more volume and you say, oh, I'm doing volume ventilation, I'm much better than the pressure ventilation team, it's not the case really. Volutrauma is also as bad as barotrauma. So we talked about that. Now let's talk about some diseases. So these are the common ones which you see if you are working with neonates. So what do you guys think here? What's wrong? This is another one. You see some loculated, air here. This is again hyperventilation, and this could be a pneumothorax, although this is not classical because you still see some markings, but again, correlate with your clinical findings. So in summary, respiratory distress in premature babies could be acute, could be chronic. Respiratory distress in term babies, most of the time is meconium aspiration, group B streptococcus pneumothorax, or congenital aphropatic hernia. Respiratory support start with oxygen. If just the nasal cannula, escalate to CPAP, go to non-invasive ventilation, which is NIPPV, or intubate and do the ventilation. And ventilation could be conventional or high frequency, and mode of ventilation could be volume controlled, pressure triggered, pressure controlled, assist control, pressure support, you name it. The idea is, which we already talked about. And weaning strategy depends upon the policies. These are certain references, so please pull those articles. And there are other many presentation on ventilation. Like I said, we are doing this one because many people requested They looked at the PowerPoint and they wanted us to do the voiceover. So I hope you guys have learned something together today. Please do like and subscribe to our channel, and you guys have a wonderful day. Thank you. Bye.